and we should be live on Facebook. And it's redirecting to Facebook. So if anyone has any questions, feel free to ask the panel. All right, we are now live officially on Facebook. It's 5 after the hour. We have to be respectful of the time of our panelists. Let me get this all set up and we will get going. Let's see here. There we go. All right, I think we are ready to go. All right, let's see here. I'm just trying to make sure everyone is on the screen. Just give me a quick second, guys. There we go. All right, let's see how I can put all panelists on here. There we go. All right. Okay. All right. I think we're ready to go. If anyone who is watching this live on Facebook, if you can confirm that you can see our panelists. I'll go ahead and do the introduction. So good morning, good afternoon, good evening to everyone. I am Dr. Akwi Asenbang, interventional gastroenterologist. I am the co-founder and board president of the Pan-African Organization for Health, Education, and Research. I am very excited to be here. It looks like we have a delay, but go ahead. Our speakers today are Dr. Funmilola Wurola, Dr. Miriam Mutebi, Dr. Larita Kabwe, Dr. Elizabeth Mwachiro, and Dr. Nobooth. She's not yet a doctor, even though I did label as her doctor. Anya Avis Nobooth is a sixth-year medical student, and she is at Lusaka Apex Medical University, a Poy Harris Scholar, and our moderator today. There's like a serious delay, so I'm not quite sure what's happening. Dr. Mutebi is a surgeon in Kenya, Dr. Mwachiro, surgeon in Kenya, Dr. Wurola, surgeon in Nigeria, Dr. Kabwe is an interventional cardiologist in Zambia. Anya, if you want to take over, I am going to stop my video. You are the moderator, you're in control. For all those watching, feel free to send your questions through the Q&A chat box, or if you're watching on Facebook, feel free to send your questions and comments. And to the audience, please remember the session is for you. This is for our students, early career doctors to learn. It's a very relaxed environment. I'd also add an extra note. A few of these doctors are currently on call, and so I totally appreciate you taking that pause just to address our attendees. And obviously, if you have to run out, we completely understand. So I will step out, and it's all over to you, Anya.
Thank you so much, Dr. Akwi. We really appreciate your warm welcome. Hi, everyone. Welcome to the Pan-African Organization for Health Education and Research Scholar Series. Today's topic, we're going to be addressing selecting a subspecialty and or a specialty, and we have an amazing panel of speakers. So really excited. Welcome to all the doctors on board. We just want to start with a few housekeeping rules. Just so that everyone is on board, this session is being recorded and it is being live streamed on Facebook. It might be available thereafter. You can also just contact us if you do want a copy of the recording post the sessions. There's also just going to be we're trying to make this also quite an interactive session. So please feel free to pop your questions in the question and answer box at the bottom of the screen, and then feel free to leave your comments in the chat section. There's no formal program, so if anyone does need to leave for a bathroom break or anything, please feel free to excuse yourself, and welcome again, and I hope that you guys enjoy it. So we know we have 5 amazing doctors on board today. And we want to just go through and introduce every one of them. Just a quick brief introduction. I know that all of you have extensive and wonderful careers and CVs. So Dr. Wuraloa, if you don't mind, maybe you can just give us a start and just give us a brief introduction of who you are and what you do. Thank you.
I'm from Nigeria. I'm a general surgeon, and I'm also an academic surgeon. I'm a lecturer at Obafemi Awolowo Teaching Hospital, Ile-Ife. I do mainly breast and hepatobiliary surgeries. So I'm so happy to be here. Thank you.
Thank you. Dr. Kabwe, I know you're based in Zambia and you're an interventional cardiologist. Can you give us some more background information about you?
Yes, thank you. So yes, I'm Dr. Loretta Kabwe. I'm based in Zambia at the University Teaching Hospital, which is currently the main referral tertiary hospital in the country. And I do mainly interventional cardiology. I was trained as a general cardiologist, but with an interventional component. But from the time I came back, I've been doing more interventional work than clinical cardiology. So that's what I do at the moment.
Thank you, Dr. Kabwe. Dr. Mutebi, I know you also have a very big passion for women, especially within these fields, and you're also a surgeon, a surgical oncologist. So would you mind giving us also a quick background about yourself?
Sure. Thanks, Anya, and welcome everyone. I just want to thank Pohar for the opportunity to be here and share our stories. I like to say I'm a breast cancer surgeon by day and then a clinical epidemiologist and health systems researcher by night. I'm a breast surgical oncologist working at the Aga Khan University in Nairobi, and assistant professor and faculty with the department. And as I said, by night, well, my research focus is primarily on understanding barriers to access for women with cancers and designing interventions that talk to those barriers. Thank you.
Thank you, Dr. Mutebi. Dr. Mwachira, you're the last doctor. It's no specific preference, just by the way. Dr. Mwachira, if you can also just give us a brief background. You're a general surgeon also based in Kenya, right?
Yeah, well, I'll start with just thanking Poha for this opportunity to just be here. I think it's a privilege. As coming right after Mutebi, I am from Kenya. I'm a general surgeon. I work in the more rural aspect in a hospital on the rural side of Kenya, which serves as a referral center for most of the southwestern part of Kenya. So I'm a surgeon and a program director who is really invested in teaching residents and running a surgical training program.
Lovely, thank you. Thank you for all your time, ladies. We really appreciate your time and effort for being on board today. So one of the first questions and one of the biggest questions I think that many young students and interns are facing with is, how does one go about choosing a specialty? So if you can guide us in any way, this floor is open.
Hello. I think choosing a specialty most times deals with, for me, I'll say it's more of what do you have passion for? It's usually easier if it is something that you like. It makes it easier when the goings are going tough. Because I'm not sure there's any specialty you pick that does not have its own challenges. But usually when you choose something that you love, something that you're interested in, even the challenges becomes easier to settle. Because people will be like, oh, surgery is very demanding, it's still demanding, but because I love what I do, it doesn't feel like it's taking the whole of my life completely. So I say, identify what you like first. Number two, identify what is easy for you to read, to understand, something that you don't need to label, as it were. If you choose a specialty that everything looks so great to you, you don't understand it. Like I used to tell people that I'm not sure I can be a radiologist because I don't see anything shadows. But they tell me that if you watch closely, you will see. But I feel maybe I will see, but it will probably take me more time than someone that loves the idea of just checking shadows, backgrounds, and all that. So I think if you like something, if it is easier for you to go ahead, is easier for you to build on the most difficult aspect of it. If you ask me to stand in a whole hour for 12 hours, it won't be a problem to me. And I'm sure it's a problem to someone else. So it's about liking it, something that you enjoy doing, and it makes it easier for you.
I agree with what Dr. Aurora said. I mean, whatever you want to do, this is a lifetime decision. This is something that you have to do for the rest of your life. So you have to choose something that flows easy. When you read the topic, you enjoy it. You like every aspect of it. So, like for me, I just was fascinated with the heart. I've never wanted to do anything else. It's a beautiful organ, and I just wanted to learn anything I can about it. So you have to, as you go through your rotations, you have to look at what really interests you. Medicine is wide. There are a lot of things that you can do from head to toe. It's wide. So whatever catches your passion, whatever flows easy to you, and when you do it, you actually enjoy doing it, no matter how difficult it is. That's how you have an idea of what you can do. Yeah.
Thanks. I agree with Fumi and Lorita that you definitely do need to find something you're passionate about. And we always use the analogy that if you're going to be up at 3 a.m., then you should better be, doing something that you love. And I think one of the issues that, I'm one of the guilty ones who used to suffer from end of rotationitis, which means every rotation you finish, you kind of want to do. And so the idea is sort of trying to narrow that down. The good thing, especially as you go through the different rotations, you sort of have a sense of what you like and what you don't like. And sometimes that becomes a little more crystallized in internship, because I think at the end of that, I knew exactly what I didn't want to do. But then in terms of narrowing that down to say, what is your specialty? What's your subspecialty? As Fumi and Lorita have said, you absolutely need to find something that, you're passionate and key about. It's not just about being good at. You can be good at something, but it bores you senseless, right? And so that's not something that anyone would recommend that you use as a lifetime route. So I would say find something that you may not necessarily have all the skills, but you're fairly maybe good at, and it's something that you can grow and develop. So I would say that would be the way to head in terms of trying to decide on a subspecialty. Thank you.
I agree with all the sentiments that have been shared by all. I say, what would you be doing at 3 a.m.? And what comes naturally to you is very important. Yeah, where do you, if you view your medical years and internship and look back and say what felt natural and what am I prone to going to naturally? I used to like going to the OR, even on non-surgical rotations. I'd be going for surgical camps with my consultants, and probably look at the lecturers that you tend to hang around with or are interested in. That's also an interesting way of looking at what you're interested at. Plus also, it helps to think beyond the internship and ask yourself, well, in 3 to 5 years, do I see myself still doing this? And if it, if you're comfortable, if there's peace in your heart that, yeah, I'm passionate about this, and I actually see myself going deeper or being a surgeon, and not only being a surgeon, but either doing research in surgery or any other subspecialty, then I would, start asking those questions early enough and introspective.
Thank you. No, I think this definitely does help a lot of students. I think so many of us do have that end of rotation-itis, because after every rotation, I'm convinced that this is the thing that I want to do. But I think the challenge that happens is, how do you find what you're passionate about? Because you might be really good at everything, and how do you narrow it down to something that is going to be both passion, or like something that you can see yourself doing, but then also be able to have a family life or a personal life, which brings me to my next question. So when you chose your specialties, how do you manage to balance between a family life or a personal life as well as a professional life and career-driven women in your respective fields?
Okay, I can go first. Okay, so first of all, medicine on its own is tough. It's difficult. It demands long hours. So even before you become a subspecialist, it's already something that that is challenging to your family. If you've got a young family, for instance, that's already difficult. And to add on to that, you put a subspecialty that calls for a lot of strain on your family. For instance, at the time I was, because before you do the subspecialty in cardiology, you have to do internal medicine. At the time I was starting my internal medicine training, I had just gotten married and I was pregnant in my first year. And you can imagine the calls and all the busy stuff that goes on internal medicine. It's difficult. But I managed to finish all the 4 years. And then after that, I had to go for another 3-year training in cardiology. And I had to lift my young family all the way to South Africa to be there. And already that's a challenge. So you need to have a lot of support from your family. You also need to have a lot of what can I call it? It's difficult to say, but anyway, it's a big challenge. But I mean, if you've decided you want to do this, then you have to go into it like your whole. You can't do it partially. Yeah, but just know that whatever you do, it won't come easy. But at the end of it, it's quite rewarding, as long as you have a good support system for you. I think that's what I will say for now.
Thank you. I just wanted to also introduce Professor Safia Marie. Welcome, Professor. She's a professor in obstetrics and gynecology in Egypt. So we're just chatting about how to balance one's professional life and family life. So your input will be most welcome as well. Welcome.
Thank you for your introductions. Thank you very much. Truly, it's difficult to have a balance between a personal life and surgical skills to be at the optimum as I wish. My specialty was an obstetrician and gynecology. At that time, when I decided to be a gynecologist and an obstetrician, it was in time in Egypt where no females are doing the job because of the difficulty in letting children at home without the possibility of a care for the children. So it make a lot of strain on me. And also at the same time in Egypt concerning to be a member or a staff in any of the national faculty of medicine, it was forbidden for female to take this specialty because probably almost all female cannot do the balance between their personal life, their duties on home and with their family, and to fulfill job requirements. However, I was nearly the first female to be a member in staff of the Faculty of Medicine, and I am professor in gynecology and obstetric since 1984. It takes from me a lot of strain, a lot of grief, a lot of problems, because when I was too young and I was a resident, once I left my little daughter, she was 1 year old, she got an attack of acute diarrhea, and when I returned back to home, it was possible to save her, and she died. And makes to me too a grief during all my life, because to learn I have lost a daughter 1 year, which she was too beloved to me, and it make to me some shock at first. However, it's a long time since that event. However, after that, I try to make a balance. I have a support from my husband because he is the doctor. I have my mother at that time make me a family support. She takes care of my kids for 1 year until I finished the period of residence. After that, I was graduated as a lecturer and associate professor and the professor. However, there is another task and there is another strain and the problem, how to be a competent female in my specialty. It took from me a learning curve over the years, and even what I would say to every young obstetrician, young gynecologist, young surgeon, it's a learning curve which never terminates. Every day you have to learn, and you have to update your skills, your surgical skills, because to be a competent surgeon, you should have a good decision. You should be open-minded. You should be completely able to separate between your own feelings and the patient which you are doing for him a surgery. However, it was a learning curve. I attended many of the conferences. I got to many universities in Europe and tried to know and to learn all the new what I am in need as personal skills and as new activities and new developed laparoscopy, IVF to my center or to my faculty in Egypt, because later on I was the head of the Department of Obstetric and Gynecology in Egypt. I tried to make a learning center. I have make attachment with different universities in Germany, in Paris, in United States, and all this attachment and these channels has added truly to my faculty, and I feel it was something for me which I felt it's rewarding from me to have many students who have learned and to have a lot of children and to have a lot of female now in Egypt. In every place you have a female which is undergoing the job of obstetric and gynecology with perfect skill. One of the important feelings and intense will inside me is that when I was young and in the beginning of my life as a professor of obstetric and gynecology, I was refusing to hear from any patient that she is coming for me to have consultation because I am a female. Usually, I insisted that every female or every patient coming to my clinic, she would choose me because I am a competent surgeon. And I insisted on this fact with my patients when I was in the faculty, when I was with my students all the time. And so I think if the female has the will to balance her life, has the will to prove herself in her job, it's a tedious and long learning curve over the years. And what we are doing, if it is for the benefit of patient and benefit of Allah, I think it is the best reward in my life.
Thank you, Professor. I really appreciate your input. That's actually a really important question as well that we've had a couple of participants enter to us, is how, like, looking at this, how established all of you women are and their programs and the way that you direct yourselves amongst your colleagues, amongst your students, etc. Did you find any discrimination or prejudice during your training being a woman? And even now as a specialist? And then also, what would you say to females within medicine?
Surely in the 18th and 19th dates, it was too difficult to be a female and to be a head of department and to be a presenting female and to be the head of the boards in many places. However, because I was in the faculty, I was present in the program of promotion of professors for obstetric and gynecology. Till 1990, it was somewhat difficult. Even when I was, it was proposed to me because I was so active to be the dean of the faculty of medicine, for example, or any official situation. It was too difficult to accept from the majority of men professors present in the faculty. So it was too difficult. Now with the National Council of Women and with the change in the behavior, changes in mind, which is present in Egypt now, you have a lot of deans of faculties in the different, dean of faculty in university, in the different faculties in University of Tanta. You have a lot of females in the official number. So now surely it is more easier than before. In addition, I was the responsible for the National Council of Women in Egypt. And this led me also to focus on my own experience to empower and strengthen the woman by my own feeling and what I have done in my life. So I think now it's more easier than before. I think there is no comparison between 1980 and now 2020. It's more, and I feel that the female now are empowered completely, and I think that the female are larger number in official situation and in a different position in Egypt now.
Thank you, Professor. Sorry, Dr. Kabwe, I was just about to go to you. I know that you're also quite very established within and highly admired amongst medical students at UNZA and LAMU. So what would your input say in terms of being a woman in medicine in Zambia specifically?
Okay. Yeah, so thank you very much. What I can say is to the female students out there that for you to train, you have to work twice as hard. It's just a fact. There's no two ways about it. Being a female makes you work twice as hard to prove yourself that you actually have the capability to do it. During my M.Med, I was the only girl in my class, and obviously I had to work twice as hard to come out top. So I was best student when I graduated for my M.Med. When I went for my subspecialty training in Cape Town, obviously the challenge there was I was first a supernumerary student, and then I was the only Black person in my class. So obviously you have to prove yourself again because I'm female and I'm Black, I had to work twice as hard once again. But in the beginning, you sort of get second guessed quite often. But when you show yourself, you show that you know your stuff, then you earn the respect and you earn that confidence yourself that you can do it. So once again, I was able to prove that I can do this. Then coming back home, obviously, the specialty that I did was, it's never been done before in Zambia. Interventional cardiology, it was non-existent until I came back. So when I came back, everything was new and I had to set up everything from scratch. Fortunately, there was a machine that I could use for doing interventions, but the entire program was started from scratch. Professor Sula Mazimba is on the panel here, and he can attest to that, see where we started from. Yeah, so in terms of working, obviously, you're coming back home, you're young, and you face the same kind of thing. You have to deal with administrators that are much older. You have to deal with colleagues that are much older. And if you get too much attention, some people are not happy and so on. But you just know yourself. You pick your battles. You know what to concentrate on, and you don't pay too much attention to detractors. So you know what is driving you, and you know what you want to do. So as long as you made up your mind like that, then nothing can stop you. So I can say my journey, 80% of it has been okay. 20%, I mean, you have challenges and so on, but you overcome them. You choose your battles. You don't let things get to you, petty things get to you. You just have to be focused and say, this is what I want to do, and I'm gonna do it. Yeah, so anything is possible. That's not to say our male students have it easy. They don't. I mean, medicine is difficult, but for my female folk, because I'm female, I'll encourage you that way, that you can do anything. Whether you have a family or not, you can still do what you want to do. Cardiology in particular is quite challenging. A lot of students run away from ECGs, but ECGs fascinate me. I love ECGs. I love the heart. Everything about the heart is just nice. And then to go and venture into interventional, that was even like, it was incredible. So it's something that it's a choice I would choose again and again and again. It's something that I can't do without. Yeah. So yeah,
Thank you,
that's
Dr.
about
Kabwe.
it.
Thank you so much. I think it speaks a lot for especially the students in Zambia, because you know the criteria or the situation on the ground as well. Thank you for your input. Dr. Mutebi, I know that you're also a founder or a co-founder of the Pan-African Organization for Women in Surgery, the PAVAS. Can you give us some more background about that? What inspired you to do that? And then your opinion also on how to, I guess, support women within the respective fields.
Sure, Anya, thank you. And sort of just speaking to the challenges as you get into a subspecialty, I think for me, my experience was, especially at the time when I was doing my surgical specialty, had an interest in general surgery. There was quite a number of people and mentors who encouraged me to do it. But equally, there were also quite a number of people who were sort of looking like, are you sure? Like, really, do you want to do surgery? Because women don't necessarily do surgery. And one of the interesting things I found, especially when I was sort of doing my interview circuit and stuff, was, again, there was a lot of bewilderment, especially from some senior professors who were just looking like, are you sure you really, why are you here, kind of thing. And it made for all sorts of weird and interesting questions sort of getting asked about, what happens, when you have a patient on the ICU and you start to cry. And so again, for me, my response was, just because I have more empathy doesn't make me less of a clinician. If anything, perhaps, the patient appreciates it more. But so in terms of doing that, what I realized is that there was quite a lot of interest, especially amongst women that I had sort of interacted with, either in Kenya or in different countries and stuff. But what we also realized was that there's high interest, but if you look at the demographic in medical school, and we said this is a triumph, one would say, of the fact that we're definitely having more and more diversity. And we have, if you look at most medical schools, if you look at the female to male ratio, it's almost about 60 to 40%. And sometimes 50-50, which is great. But if you look at the surgical specialties, that sort of narrows down to less than 1%. And we're like, hang on, what's going on here? And it's not through a lack of interest, but what we noticed was there's a very high rate of attrition, meaning that people would start, and like I was talking to one of my colleagues, and she was like, she started off in a class of 12, and then by the time she was done, she was the last, lady sort of standing. And whereas that may reflect more of, again, the traditional sort of models that we've had, especially with specialty training, where you sort of, the idea was to sort of, have a sort of low base, a pyramid of many people, and then gradually whittle those down to remaining few. We noticed that was especially common for women. And so we said, hang on, could we potentially come up with a way of supporting each other and, helping each other sort of go through the process, because it's something that we love. It's something that we're interested in, and I'm sure it's not just us. So how do we create a network or forum that can provide support for women throughout the continent who are looking to engage in surgical specialties? And so the Pan-African Women's Association of Surgeons is definitely trying to provide a platform for these women and looking to provide mentorship and support. But for us, because again, if we look at the burden of disease, especially in sub-Saharan Africa, we're saying there's over 143 million additional surgeries needed to prevent death and disability. And we're saying that women have a unique role to play, especially in our communities. And so the idea behind it is, one, yes, we would want to increase the number of women in surgical specialties, but it's not just women for women's sake. It's not just a numbers game. We're looking at how do we give these particular ladies the skills to make them transformational leaders in whichever capacity it is. And, sometimes you think a leader has to be this big, post or whatever. We're like, no, in whichever locus you are in, whether it's a small clinic, whether you're doing policy, whether you're in charge of a big hospital, how do we give you the skills to advocate, support, and improve healthcare? So that was kind of the ethos behind that. In terms of how do we address challenges, I think I would echo pretty much the sentiments that Loretta had said and Prof, in that you pretty much have to realize that, unfortunately, there's still many conscious and unconscious biases, whether it's from your patients, whether it's from your peers. And so the onus is on us to actually do your best, because at the end of the day, despite all the biases, as soon as you start, and some of these biases unfortunately come from a position of ignorance. So the onus is on us to sort of, shift those narratives and shift those, perceptions that people have, because sometimes people think, oh, you're female, or you're Black, or you're whatever, or you're brown, or you're this color, whatever, you can't do this. But as soon as they start to interact and realize, okay, hang on, she knows her stuff, she knows what she's doing, she's competent enough, she's, empathetic, as long as you're consistently, doing the right thing and working hard, then you actually have a chance to shift the narrative. And so that's what I would say is important and critical in terms of, changing the story. If we all show up, do our best, and then we build more and more individuals into these specialities, then for sure it's a win-win for education and for our healthcare in our regions. Thank you.
Perfect. Thank you so much, Dr. Mutebi. Dr. Mwachiro, I know that you're also part of the chair lady of the Kenya Association of Women Surgeons. Tell me, did you also have any or face any discrimination or prejudice when you came to specializing within your field, and then currently as is now?
Also, I'll say for my in my training, 50% of our residents have always been female. So I always knew from quite earlier on that I wanted to do surgery, and things kind of start themselves in a way to get me to where I am today, which is a hospital I have been in the last 10 years. I was trained in this same institution. I have remained after residency, after my internship, 2 years of practice and then doing residency, partly because I was really amazed at how in one particular institution, there was so much acceptance of the female doctor among the colleagues, not the patients. You know, within the patients, we're still African, so most of the patients would still see you as the nurse as opposed to the doctor. But irrespective of that, a lot of us just always give the best in whatever we do. So gradually, in a span of 10 years, I'm really in awe that if within every single year that we took residence, and I was a resident, we had at least a small program as it is, we had at least 1 or 2 female residents, which made up 50% for the years. I did not feel at any point any discrimination in any sort of way. It's more, as Dr. Kabwe said and Dr. Mutebi, it's more of sometimes you have that unconscious bias or the imposter syndrome, as Prof mentioned, wanting to, feeling as if you're not good enough, or why would they come to me? But a gradual realization that you're good enough, and the patients always still come back and they request for you, or the consult still comes back to you. But in essence, you know, as it can't be put in a better way than what Dr. Loretta said, you have to work twice as much. You're balancing very many things at one go, within work and outside work. And there's a humility that you have to have, especially within our setting. One, not to prove yourself better than anyone else or better than the male. It's harder on both sides, but to want to make it easier for the next person who goes through this journey, be it a female student or a male medical student. Just so I'm a teacher by profession, so just wanting to teach, as I am a surgeon or surgery, equally to both male and females, for the love of it and for the quality of what you're training and what you got for the betterment of healthcare.
Thank you. I think that's really good news to hear that it's actually the numbers between male and female within the field is also rising, and then the ratios are balancing itself out. Dr. Wuraloa, can you give us some input on your side?
Yeah, thank you. Let me just cap it up with what one of my friends told me when I was about to start residency. He's actually a guy, he's a doctor too, but he said something. He said some people will like you because you decided to do surgery. You are challenging what is not the norm. Some people will hate you for everything because you decide to do that. And some people will be indifferent, so it doesn't really matter. What matters is you. What do you want? And I think that really helped me all the way. So if anybody is acting somehow, I just feel like, okay, they've told me that it's not everybody that would like me anyway. And I see some people, they're so all over the board, trying to make my life better. Like, oh, have you eaten? And when last did you go home? Like, I have some bosses that are now worried about my life. And like, at the same time, I have people that doesn't give a damn. Like, you decide to do this, you have to be here. Someone had told me before inside theater that I don't like operating with a female. And like Miriam said, it was just an unconscious bias. He just said it. He didn't feel he didn't think it was hurting me. He just said it. I don't like operating with a female. And I just smelled that you are stuck with me for this surgery. That's just it. So the point is that for females, there are some expectations from you. Like Miriam said, everybody thinks you are going to be so soft, crying at every point, which doesn't really matter. There are some males that are emotional and there are some females that doesn't express emotion. So some of this does not come with your gender alone. There are more of stereotypes that people have placed on you. You're expected to be this, you're expected to be that. So I just say, do what is important for you. Be yourself. Don't try to dim your light for people. And don't always attribute everything to because of your gender, because it doesn't work that way. Sometimes people are just not nice. It doesn't have to do because you're a female or you're a male. It is just who they are. So if you don't see the bias and you just do yourself. And most importantly, like I tell the junior colleagues that please and please make sure that you do your job well. Even if somebody does not like you, if you do your job well, they don't have a choice. I'm sure Miriam can attest to this. People come to our clinic because she's a female breast surgeon. I see that every time. People bring their wives to me, even if they don't like me, they don't have a choice. They don't want a male to see their wife. They'll bring the wife to me. But that's not because I'm just a female. It's probably because they know I can offer something. If it is just because of my gender, they will walk away. But they need to be sure that you can do it. And again, people will second guess you. It's just normal. When I was training, I was practically the only female in my subspecialty. So there's no way I will not be second guessed. Every time all they've known is seeing a male enter the theater room. So now seeing a female taking over, it's just normal for them to feel like, are we sure she's going to know it? So it's just the onus is on you to be able to say, I'm going to do it. And why I'm emphasizing is that don't overburden yourself with wanting to prove yourself at the same time. I think I made that mistake when I first started. I was weighing my life down just about people's expectations until the day I decided to tell myself that I didn't come here for anybody, I came here for me and to help my society. So because of that, I became more relaxed. It was easier for me to learn, to assimilate, to follow what people wanted. And all those little distractions, just see them as part of way of life and move on. But if somebody treats you the way you don't like, make sure you express it to them and have a clear mind with it. But don't always attribute everything to your gender, because sometimes it doesn't have to do with your gender. Thank you.
Very true. Thank you so much, Doctor. I'm just taking some questions from the audience. Someone has asked, how is the pay and work-life balance in surgery versus medicine? So I think most of the women here are also surgeons. So maybe we can combine that with another question of how important was compensation in choosing a speciality.
I say money is good. I'm an advocate of money is good. Yeah, Dr. Loretta, that is true. Money is good. Money stops nonsense, as they say in Nigeria. But at the same time, if you choose specialty based on money alone, you will be overwhelmed. You will not do well. Because I tell people, if you do well, you'll be compensated. Even the Holy Book says that if you are diligent in what you do, you will stand before great people. So it's just normal. Do your work very well. Don't let money alone be the motivation why you are choosing a specialty. In as much as you have things to, you have other bills to pay and all that, I think everybody should learn about how to handle their finances. But choosing a specialty solely on what they are going to pay you, I'm not sure it's going to end well. But I will let you know that even the specialties people think doesn't pay, for the very good people that does well, they earn well from it. So it's about your skills, it's about what you are selling. So it is not really about surgery versus medicine, interventional radiology versus this. No, it's not really about that. I know that you'll have seen lists like US, UK has like these grades of who is the best paid and all that. But I can assure you that even the best paid specialty does not mean that doctor is the most wealthiest of all compared to the least paid. So there are so many other factors to it. So I would say don't choose specialty solely based on financial compensation, but money is good.
Thank you, Doctor. I hope that answered your question. What skills and qualities can medical students develop in order to prepare for a career in surgery? I think starting from medical school or starting before internship, what can we do if we do have an interest in pursuing surgery? I think this is open to anyone.
I'm not a surgeon, so I'll let that one
Well,
pass.
I could try and answer that. Sorry, I thought you were going to ask direct to somebody specific, but I can go first. In terms of trying to, if I understand the question, what can you do if you're a medical student? I think now more than ever, there's quite a number of opportunities to get involved in areas around surgery. What we usually when you're in med school, you find that there's a number of these days there are quite a number of short courses that are run in basic surgical skills, and during your rotations for most of med school they have you do have a logbook that you do have to have a couple of procedures, and this might be minor things like doing suturing, putting in chest drains and stuff, but there's lots of opportunities to if you do have an interest, I would say find a mentor and who you can shadow or engage with, and then the other thing is that I would say and tribute to the medical students these days, there's so many medical student surgical societies that tend to liaise with the surgical societies that exist in country and in the region. And like what Liz was describing, they really welcome students to come for for the surgical camps, come look at all the aspects of the camps, whether it's the screening, the actual surgery, the post-operative care. So that helps to give you a continuum, because sometimes you sort of think of, yes, I want to do this, that, or the other, but until you sort of have the actual experience of it, then that could help either crystallize your mind towards it or say, you know what, I absolutely don't want to do it. Now, the other bit that I would say, and what I find fascinating, and this is what we sort of try to encourage our students and residents, is that sometimes there's a perception that there's a perception that I want to join surgery because I'm good with my hands and I don't want to think. We say, no, listen, surgeons are physicians who operate. So, we always say the actual cutting is only a little slice in what happens. And what actually happens is what really changes outcomes is what you do before the surgery and after the surgery. That is ultimately what makes a difference in terms of your surgical outcomes. And so patient selection is critical. Sometimes there's some of these adages that go around and they're saying that, good surgeons know how to operate, better surgeons know when to operate, but the best surgeons know when not to operate, right? And so as part of my mentor says, you can always correct anatomy, but it's always physiology that will kill the patient. And so having a good sound grounding in the basics of that and in your surgical career will definitely go a long way. But I would say, I think Fumi's just shared a link for incisions, and there's lots of other global communities and regional communities that you can tap into, definitely if you're looking to explore your interest in surgery. Thank you.
Yeah, just to also add on to that, I think focus on your medical years as you're doing your medical, your first degree. Really be good. Know your anatomy well, know your pathology well, know your physiology well. Those will help you when you start doing your masters or specializing more into doing a surgical subspecialty. Part of your training in surgery would entail that you have to do your basic surgical skills. You have to do some knot tying, you have to do some dedicated time working on just getting that skill. A lot of people in our setting during their internship feel that they have become a doctor and, I'm good enough, you don't have to train me now. I know my basics because I did that way earlier. So I think if you do your medical degree well and focus on really being good, a good general doctor would really help you. As Miriam has stated, we are just physicians who've chosen to do the surgical aspect, but that comes in almost all my patients. You will be the critical care surgeon at some point. You will be the person who's taking the pathology from the patient. You'll be the one who's breaking the bad news. you'll be the one who's referring them to other, other specialists. So I think as a medical student, focus on doing your, completing your medical degree really well. And then, get a mentor, get someone to work with you who will actually create that niche or open your mind to, okay, what in this specialty am I interested in? And how can I, how can I be part of it? It can be this surgical skills labs. It can be joining part of some research, researchers that are key, and I think I participated in a lot of writing a lot of papers or collecting data for some research papers as an undergraduate, and that really helped me, or it kind of showed me that this is what I wanted to do. So yeah, I'd really encourage the medical students to also think of research and start thinking of different more simple papers that they can start working on.
If I may add now on the medical aspect, similar to what my colleagues have said, as an undergraduate, obviously you have to do well. Then to sort of catapult yourself to what you want to do later on, you need to show interest in that particular subject. For instance, when I was a medical student, I showed interest in ECGs. I would go to the echo room and pick up ECGs and report on them, take them to the cardiologist, she reads and then gives me an answer and so on. So you have to show interest as a student. You don't have to wait for the doctor or the lecturer to push you, because we are busy, we have patients to see and so on. So if you don't show interest, no one is going to come to force you to learn. So you have to show interest on your own to say, I want to do this. If your consultant sees that you're interested, they'll be calling you. They'll be spending that extra time on you to train you. So it's up to you to show interest. I can give another example. When I was doing my MMed, before I went for cardiology, what I did, I registered for an online echo course just on my own, because I wanted to learn echo before I did the actual training. And I did it myself. So you don't have to wait for the formal thing to happen. You just have to show interest on your own, have that drive on your own that you want to do this. If you want to do intensive care, for instance, spend time in ICU, extra time away from your allocated time. I know you're in rotations and so on, but that particular thing that you're interested in, try to spend more time, additional time doing that, apart from the other work that you're assigned to. Yeah, so what I see a lot among students is that lack of drive, where they want to be spoon-fed, they want to be told everything, they want to be given answers to everything. That doesn't work. You have to show interest. If you want to learn, you have to show interest. I think that's the message I have for the students there.
Thank you. Well, can I add that if I have to choose to be a surgeon, or if I am a medical student, I have at first to discover myself, because to be a surgeon, it needs personal skills, it needs mind skills, it needs hand skills, it needs personality skills. So when I was a student and I was looking for what specialty could I choose, I prefer gynecology and obstetric, because it is a lot of pleasure and it is a creative job. Usually females in Egypt, when they have a baby, we have usually many festivals, and the people are too happy to have a baby. So it's creative. However, when I was looking for medicine, it's a long-term treatment. The results are not so rapid. So in surgery, usually you have a creative and a rapid result, which is makes pleasure to people. If we are doing a cesarean section, a normal delivery, a gynecological operation, all are successful at the time and you have the result immediately. So this is one of the intense feelings which I felt, and I preferred to be a surgeon. So long as I decided to be a surgeon, I think that one of the best things is to have to look with interest to the branch you have decided to be a surgeon, or the branch you have decided to work in. So looking all the time to every step during surgery, whether it's a junior professor or a senior professor, you may get any possible addition to your skills. Regarding the personal skills, you should be steady. You should have a social life, quite social life. One of the main steps to be a good surgeon is that you can discriminate between your social life and your job surgeon. So when you are on the operating table, you don't remember anything except the patient which is lying on the table and what you are doing. And every time with the first incision or with the trocar of the laparoscope, when it is introduced into the abdomen of the partner or the abdomen of the female, usually you have a sense of fear on your patient, even you have done a lot or millions of operations, because each operation is different from the other one. Every you have usually to be open-ended in adding to your skill, looking around junior and senior all the time. In addition, everyone can discover himself. What skills does he have? Is it fine skills to be an ophthalmologist, or is it coarse surgery? It's a mixer between fine and coarse surgery, laparoscopy surgery. Now, with the presence of subspecialty, I think that most of people should insist on having and learning on this subspecialty, which makes the learning curve more rapid in growing, and more learns and more skills are required. In addition, medical students have to make the balance between their personal skills and faculty skills which are present, and the possibility of having a good learning curve in this institute.
Thank you so much, Professor Marie. We're going to be wrapping up soon, so I have some specific questions for some of the doctors on board. Dr. Wiraola, you also studied abroad and did your specialization abroad in New York University. What was your process in terms of going over and then also studying abroad and coming back to your respective country? This is also open to the other panelists, but if Dr. Wiraola could answer that first. Thank you.
Okay, the training I had was actually online training. It was a research training with Harvard. So it didn't involve me with going. But then I've had to go for some other trainings, hands-on training. So the issue with that is that, like, if we are going to go to the UK, you have to like have some register with their board, the GMC, which usually takes some time. In US, you need to do PLAB. But if you don't do that, that means they will not allow you to have a hands-on. So I've had to do some observership because of that. You will not be able to touch the patients. But like the surgeons there will attest to it. It usually gets boring for a surgeon after like a month and you are observing. So I will advise that now that you are about to leave school, you are still in school, you can start thinking of where you can get some trainings. Like in Nigeria now, there's some trainings I can't get in Nigeria. Although almost every other basic training you can get, but to super subspecialize, you can't get them. So you can be a general surgeon, you can be a pediatric surgeon, but if you don't want to be a hepatobiliary surgeon, you have to leave the shores of the country. So if you are thinking about something like that, you need to start thinking of which place is the best available place. Another thing I can advise is that India is a very good place to train. If we can identify a good place in India. And that's because India allows us, anyway, for Nigeria, and I'm sure for most other African countries too, it allows you to touch patients when you get there. So by the time you get to India, you're going to register for the India Medical Council, and you'll be allowed to touch patients. And another reason why I like India is the fact that things you learn there, you can adapt it when you get back to your country, compared to if I go to Europe or I go to US, because in Europe and US, because of the well-structured insurance schemes, Sometimes they will open an instrument and discard it at the same time. My Nigerian in me will be like, that kind of billions of dollars, you're just discarding like that. Do you get? But if you go to India, they will show you how you can recycle. They will show you how you can fabricate the one that can be locally made. And it makes you a better surgeon in the sense that you have exposure in US, you have exposure in Europe, and now you're getting in India. So when you get back to your country, it's easier for you to adapt them into helping patients. And you just didn't train, wasting money, but you have trained and you're able to use it and set up a skills. Just like Dr. Loretta said, she came back to be able to set up a skills in her place. If she had gone to a place where everything is way above what is available in Zambia, it becomes difficult for her to adapt. So always think about being able to adapt. So that's the important thing. So, and if you are going outside the country for training, there are some places I know when you want to go to US, there are some places that they will be the ones to help you look for visas. So they give you a better visas. You don't have to be denied over and over again. So always think of places you're going, the support system they are ready to give to you. But most importantly, for you to be able to touch patients, it's always good to be able to register with their local councils. Thank you.
Perfect, thank you. Dr. Mutebi, how do you balance research and clinical work?
Very unsuccessfully. But I think part of the trick around that is to actually do research around your patients. And because sometimes we sort of look at clinical work and research as separate. No. What I try and do as a health systems researcher is trying to find or trying to solve pain points for patients. For instance, you'll say, for instance, we notice that we see a lady maybe a month in and she takes another, we do a biopsy and she probably takes another 2 months to come in, and we say, hey, what's the problem, right? And she says, oh, I needed to get funds to pay for this biopsy. And we're like, okay, so why are there difficulties with the biopsy? And that's a research question right there. What is the pathway from diagnosis all the way to treatment for the patients, and what are the sort of loopholes that that patients are having to jump through in order to access care? And so even in terms of your research, you also have to think about what's relevant. Yes, it's nice to sort of look at some weird and wonderful esoteric molecules, but how does that actually translate to the patients that you're treating? And so as a health systems researcher, the whole basis behind my research and work is pretty much looking at what challenges my patients are having, doing interventions, and I say, okay, if I do this, does that help to make the journey a little better? And that, I think, at the end of the day, is more impactful. And so when you also do that, then you're invariably, doing both. Even as I see patients who come in to my clinic, and I would say, listen, we're, as part of your care, we're going to give you your care, but we would also like to learn a little more about your journey to see if we can help make it better for the next patients coming through. And most patients are more than happy to do that. And so, of course, having said that, you still do need to make dedicated time. At least 1 day a week, I try and reserve specifically just to look at my research and what's going on. But yeah, it is a balance, but it helps. It is a difficult balance to navigate, but it helps if you ultimately end up doing research around your patients and answering their pain points.
Thank you so much, Doctor. Dr. Machiro, this is a question for you. How do you balance clinical work and program directing at the school that you've started? And how did you start the school while still being a surgeon?
So I'm a program director so I teach surgery in the program that I am in, which is part of a program within the Pan-African Association of Christian Surgeons, which is an American organization that works with the College of Surgeons of East Central and South Africa. That's different from directing a school, an education school for children, which a school should run on its own. So I'm the director, but there's a whole system that's in place and I just oversee. On this other side, program directing a surgical program means you are taking up a number of residents under you within an institution and working towards ensuring that they get proper surgical training in a given number of years. So they have their basic 2 years before they get into their specialty years where they get a fellowship in their surgical training. So that's really, it's rigorous. I was first an assistant program director. I just became the program director early, somewhere mid this year. It's fulfilling in that you see younger doctors who come in when they are, pretty young in their vision and their dream of becoming a surgeon, go through the rigorous training. And eventually, surgery is more of an apprenticeship type of training. It's graduated responsibility within the years of their training. So it's a pleasure to be the person who tries to ensure they get proper skills, proper education in classes or through curriculum, but also through clinical OR time and also lab time. So plus research. So it's what I do Monday to Monday in planning emails. So it's a combination of you being in the OR with them, but then also taking the time to network and create avenues for them to rotate within the country and outside the country. So for the medical students, even as and interns, as they go into a period of time where they start thinking of, okay, so I think I want to do surgery, or I think I want to specialize into this, know that some of these programs through many organizations are even available in Africa. And through the different organizations within Africa, you can get fellowships. Miriam did hers in South Africa. So it's more of creating networks and starting from where you are and eventually growing into what you want. But through the world has become such a small place for you to be able to get these specializations in graduated forms over a period of time.
Thank you so much, Dr. Machiro. Dr. Kabwe, I have a couple of questions for you. One, how do you become a cardiologist as a Zambian student? And what are the advantages and disadvantages of doing a specialty outside of Zambia, and then in your instance, in South Africa?
Okay, so for the Zambian students, obviously, if you want to pursue a subspecialty in cardiology, first you have to do your MMed, internal medicine. That takes 4 years. And then you have to identify a place where you can do cardiology. For me, I was fortunate. I trained from Stellenbosch in Cape Town. And I sort of applied for that post 1 year before I completed my MMed. So you don't have to wait for you to complete anything. You can, because places are limited there, especially for these subspecialties. You don't get in easy, especially if you are not a citizen of that particular country. So for me, for my subspecialty in particular, there was only one slot available at Stellenbosch for a supernumerary registrar, and I was fortunate that I got that slot. I actually, when I applied for it, Prof invited me for the interview. He gave me an option of whether to do a phone interview or to fly there. But I knew I wanted this thing so much. I flew there. There were 7 other people that were interviewed. And I don't know if flying down there added to my getting the place, but it showed that I was determined to get it. So yeah, so apply for these trainings way before you even finish school. That helps a lot. Sorry, what was the other question?
What was the advantages and disadvantages in studying abroad and then coming back to Zambia?
Okay, so advantages, Cape Town is beautiful. I was in a very nice hospital. Like every day you go to work, you're happy because what we were doing there was fascinating. Imagine a patient comes with crushing, horrible chest pain, they're diaphoretic, they're vomiting, and you don't have to cut anything. You just access the radio artery and you push your catheters and wires there and you open the vessel. Talking of instant results, that's pretty instant. So the patient becomes pain-free instantaneously. So yeah, there were a lot of good things training in that place. I had a very supportive team. The group of professors and consultants were very supportive, and they held my hand all along. So obviously, I can't predict the other places how their training is, but if you're lucky enough, if you're fortunate enough to go to a good training center, then you'll be trained very well. I must say I was trained very well. And for instance, for the clinical exam, I didn't need to read much because most of it was taught to me again and again and again. So it was like answering questions that I was practicing daily. So yeah. Then in terms of disadvantages, obviously you have to, you have a small family. If you have a family and so on, that's difficult. You're training for many years. Cardiology is 3 years. Subspecialty is 3 years. If you're going to do the whole thing, obviously there are smaller courses like you can do echo for 1 year. You can do EP and so on. But if you want to do the whole thing, it's 3 years. So that's 3 years away from your family. That takes a toll. And then you have to think about where you live, for instance. In South Africa, obviously, it's known for crime and so on. So yeah, I had to pick a place which was sort of a semi, well, it was a good neighborhood, gated community, just to get enough security. But you should realize that that would be expensive. So that's the other thing you have to look at. You need to go with a good sponsorship. You have to find a good sponsor before you go there. For Zambian students, unfortunately, at this moment, the government is not sponsoring any outside training at now. I hope they start eventually, but I was on a government scholarship, and you know, it's not easy also being on a government scholarship because the money doesn't come on time, if at all it comes. So there were times when I wasn't paid and I had to pay rentals and so on. But fortunately, with the support from the hospital I was training at, I was able to be given some grants and scholarships, and that's how I managed to finish school. So it really depends on where you go. But before you go, make sure you've got a good sponsor because life out there is expensive. And then you should have a good support system when you're out there. If you can take someone from home, that helps a lot. Yeah.
Thank you.
Yeah. Then come. Yeah.
Just one more question, Dr. Kabwe. Did you go into internal medicine knowing you wanted to do a fellowship in cardiology, or did you decide in cardiology while doing internal med?
Oh no, I went into internal medicine with with the view that I'll do cardiology. Like I said earlier, when I was a medical student, I loved ECGs. So when I went into internal medicine, my focus point was I want to do cardiology. So in my second year of internal medicine, I enrolled for that online course I was talking about, and I taught myself echo. So I went in there knowing what I wanted to do. Yeah.
All right, thank you. Professor Marie, I have a question for you. Do you think that men find it difficult in the field of obs and gyn with regards to patients being comfortable within Africa? I don't know if Professor Marie is there. I don't think she is. Okay, well, when Professor comes back, we'll ask her that. Dr. Mwachiro, I know that you have a background as well, being exposed to homeopathy. So in your opinion, does homeopathy or any other type of complementary medicine play a role or play a part in surgery, especially surgical related hospitals?
I think homeopathy really focuses on wellness and how you can use natural medicine for wellness. The surgical principles are mainly if you have an obstruction or if there's a problem or if there's a growth, you have to either do a resection depending on the pathology or release something. So while homeopathy focuses on wellness and how to treat a fever or pain, and there are drugs that are more natural, I guess maybe in the treating of it, that's not surgical, it would play a role, but from a surgical perspective, it would be more preventive before the operative aspect. Yeah.
Okay, thank you. Sorry.
Annie, can I answer, Annie?
Yes, please, Professor. Thank you.
Yes, thank you very much. Concerning the question, the last question about homeopathy, we have a research here in Faculty of Medicine, Tanta University, Egypt. However, it doesn't fulfill, or it is not well accepted by the majority of professors. And so it was too difficult to continue homeopathy with the scientific basis of obstetric and gynecology in my department. Concerning the females, are more comfortable with female? I think so, yes, now, because we have competent surgeons and competent obstetrician all over Egypt. However, we have social habits, and we have old beliefs in Egypt. However, they are minority of people who are still looking that there is a discrepancy and gender discrimination, and some men are more competent. However, for the time being, I think that the female have the upper hand and have a better opportunity and have a better number of clients in Egypt concerning males, male doctors, particularly in obstetric and gynecology, so long as the female was competent as a surgeon and as an obstetrician.
Thank you so much, Professor. This is one last question, and this is directed at any of the specialists, because we've already had Dr. Kabwe touch on how to, or the process of applying for her specialty, but do any of the other specialists have any advice on application processes within their country or abroad that they know of? Thank you.
Hello, I'll say with the advent of internet, it makes life easy for everybody and you can reach anywhere. So if you're interested in a specialty, make use of social media. It's a very good place to start. You can have mentors that doesn't even know you, that you are their mentee now. You can see some people online that you like, or it's like, okay, now I like breast surgery and I'm following some breast surgeons online, something like that. So you can follow them. Some people post about their faculties, about options. You might start looking into it. If you are in Zambia and there's someone that you really look up to, you can look for them on social media. It gives a better platform to talk to people. Follow them, see what is being done. I am of the opinion that internet helps a lot now. So you can start checking as a student randomly about things that you like. If you're interested in cardiology, what are the centers in the world that does very good cardiology? What are the qualifications? So you have an idea of what is expected of you before you get there. There's some trainings that when you're applying for and you needed a scholarship, the scholarship process needs things that are not necessarily medical. You hear people asking you, what have you done for your community? What do you intend to do for your country? But if you don't have anything that you've done before, that might count against you. So if I'm working towards a particular place or a certain scholarship, I might start thinking of, okay, this is what is needed. Now, Chevening scholarship is on, but that is strictly for academics, masters, kind of. You can start following people that have received Chevening in the past. Like I'm a Commonwealth scholar, so you can start checking Commonwealth scholars online, and you'll be able to see how you can apply for Commonwealth scholarship, what is needed of you. And Commonwealth is a very good place to start if you need to do masters and all that. They give you everything that you need to make your life easier. So things like that can help when you're searching for subspecialty. So start looking out for the kind of subspecialty you're interested in. Start looking out for programs online and what is required of you. I think that would be a good step.
May I just add to that? In addition to what she said, give yourself an opportunity to network. For instance, you can, as a student, attend these congresses that are there every year. There are so many, for instance, for cardiology, there are so many. You can identify one congress and look for a sponsorship and attend that congress. Those are opportunities for you to network with the top range, the owners of schools, the deans and so on. So for instance, if you've got a nice case that you treated with your consultant, you can write up such a case apply for it, submit the case online, and then say, I want to attend this conference. There are so many people, so many industries that can support you to attend such things. Apart from using online media, of course, try to find opportunities where you can network and get connected with people that, with people that have the specialty you're interested in as a student. So you don't have to wait for you to start your MMed. You can start as early as you are.
I agree. I think what Loretta and Fumi are saying is absolutely correct. You do need to find opportunities to network. And I think it's important to realize that one of the biggest investments you can make is in yourself. And so trying to, aggressively trying to, find these opportunities, doing your homework. In terms of subspecialty training, you will probably find that depending on where you are, if you're looking for doing them in country or out of country, there's quite a number of processes that are needed. For instance, if you're going to the UK, you need to have the GMC registration. You may need to do some preliminary exams, similar to the US, where you have to do the USMLEs. And to be completely honest, the best time to sort of do that is just, in your exit exams from your fifth year medical exams, because they're sort of similar, because they're talking about obstetrics, depending on the steps, either your obstetrics, surgery, internal medicine, and pediatrics. And so one would say that's probably the time when all of that is fresh in your mind, as opposed to down the line. So again, start to do your homework. And if there's any exams or registrations needed, most of those take anywhere from 1 to 2 years. So it helps to start early. But I think I would actually want to challenge you a little and say, maybe take a step back and say, find your why, right? Because sometimes I talk to students, and sometimes you ask, okay, I want to do cardiology. Why? Because I want to become a cardiologist. I'm like, that's not an end in itself. Like becoming a cardiologist or becoming a surgeon or becoming a obstetrician, or you need to figure out what it is that you want to do with that. So just having the paper, just having the qualification, and unless you've thought deliberately about it, then you may just end up accumulating papers with no great merit, right? I always say, for instance, that I'm in the hope business, because for me, my work is trying to change the narrative around cancers, especially women's cancers in our region. And if you talk to all the excellent people on the panel here, they'll tell you why they're going into their specialties. So I would say, find your why, and then now take deliberate, concrete steps towards building that, whether it's whichever specialty you want to build a network, engage with people, and gradually take steps, concrete steps to work towards that. Thank you.
Just to add on to that, I think there's a question that has been asked Dr. Kabwe about any links to organizations. You can start as easy as go to the Zambia Cardiology, or as I'm assuming there's an association of cardiology in Zambia, for example. There will be a Kenya Association of Cardiology. So think of a Surgical Society of Zambia. In East Africa, Surgical Society of Kenya, there's POWERS, there's Kenya Association of Women Surgeons, there's the College of Surgeons of East, Central, and South Africa for SEXA, there's a WACS for West Africa. So those are avenues for you to just see and try and network, and take the opportunity with COVID to just maybe even get free registration to some of these scientific conferences. SES is currently open. You can get an open virtual conference that you get free registration into. The WACS, the Women Association of Women Surgeons, will have their second conference somewhere in October, and you get free registration into it. Harvard, Brigham, and Women Hospital have free access to some of their training. So just start with one, and they kind of, with social media, and they link up and, use some of these other portals, LinkedIn, follow someone, get an opportunity, send a an introductory message of some sort and say, hey, yeah, I would like to be mentored by you, Prof. Marie, you know, in a sort of way. And I think in one of those reach outs, you will get assistance. And then, yeah, ask yourself why. I loved surgery, but then your why ends up opening into another journey and another journey. And you realize that the moment you ask yourself the simple questions of why am I doing this and try and understand where you're coming from, it takes you to another notch higher. Well, and that will drive you. I am happy that within what I'm able to do, I'm not only doing surgery, but then we are impacting the next generation. We have more surgeons just by training and empowering women surgeons. So that's a plus. That's more surgeons for Africans. That's more cardiologists for Africans. That's more obstetricians, and hopefully we've impacted medical students who would you know kind of move on and do what we've done many years later. So there is a why to why. There has to be a why to what you're doing.
Thank you so much. Thank you so much to all our panelists. Unfortunately, we've run out of time. So there are a couple of questions, but we're not able to get to all of them. So we really apologize for all of that. But I hope that everyone has enjoyed this. And all the attendees, thank you so much for coming on. I'm just going to hand over to Dr. Akwi to say the final thanks. But to each of the inspirational women on this panel, thank you so much. I personally have narrowed down and found a lot of inspiration from all of you. So please reply to my emails when I spam you with questions. Thank you so much.
I love it. Once again, thank you guys so much. Totally appreciate your time. Anya, that was brilliant. And to the audience, for some of the questions we did not answer, I know there's a question about being a psychiatrist. There's a few private questions about, anesthesia. We'll, try and set up something else for a mentorship. I think one of the things I've learned here is, like you said, this is a powerful audience, and yet they've been able to balance both their personal and professional life. As they said, you do what you like. And we have a message, and I'll just read it directly. So from the co-founder, Dr. Sula Mazimba, who personally states, I salute you all for the great accomplishments despite the current of bias and prejudice. Thank you for the sacrifices you have made to society, even at the expense of family and personal life. And, we totally echo those sentiments. We are absolutely grateful for your time, and I can't thank you enough. And I'll be stalking you again. We've got so many upcoming events where I will 100% stalk you now that I have your phone numbers, cell phones, and I know where to find you. To the attendees, send us an email. If there's anything in particular you'd like to hear, feel free to send it to us. Continue watching on the Facebook page. We'll try by all means to meet your needs. We'll try and answer your questions directly via email. Once again, thank you to everyone. Have a good morning, good afternoon, good evening, wherever you are. We appreciate your time. Have a great day, and thank you for all you do.
Thank you,
Anya.
Okay.
Thank you, Anya.
Thank you, everyone. Have a great day.
Thank you, Anya.
Thank you. Bye-bye.
And it was a beneficial and a good meeting. And we are looking forward for your email and waiting for reply.
Thank you. All right, thank you. All right, meeting ending.
Okay.